And share. I am going to go ahead and share my slides. I'm just going to say I don't have a lot of slides, so don't worry, it's not going to be a lecture or anything. It's going to be more of a conversation. And I'll have Genesis help me with my poll when it's time for them. So thank you again, and I'm very excited to lead this conversation. Genesis, if you can help me with the first poll question. Do I need to stop sharing my slide?
I was able to take your question while your slide was up, Nasima.
Yes, I think Genesis had that question. Do we have the results? So we do have the results, and it shows 100% of individuals here have actually heard of patient navigation, which is really good to know because we don't have to go into the details of it and talk about patient navigation and what they are and what they do. So I will focus the conversation on some examples, some scenarios, and take questions from the audience. So next question we have is, have you used these groups to support your patient care research subject? We'll give another 30 seconds to share, have everybody answer. So majority of individuals here have used patient navigation for patient care, research subject, or community member recruitment, which is great to know. So today I'm not going to go into the history, presentation, and future of navigation. I will discuss some example navigators, what navigations do, and also how they can engage our community, and more in order for us to succeed in what we do. We are here to help our community live a healthier life, and our navigators, community health workers, social workers, they're here to support us and provide us with the best support that we can get. So to start off with, I would like to discuss a young female under 30-year-old breast cancer patient that showed up with a lump in their breast. Now, this woman was uninsured, came to navigators for a walk-in Wednesday. Upon having conversation, the navigators learned that this person is symptomatic, has a lump on in their breast, do not have insurance, and most importantly, was afraid and nervous for coming in for care. So the navigator talked with the patient and said, hey, you need to be seen by a doctor. We can't just have you do a screening because you have a lump. Let me take you to our screening services, which is actually our survivorship team at Miles Square Health Center. And so the navigator walked the patient up there and assisted her to register and came back down. A few minutes later, navigator notices patient is angry, upset, and is walking out. So the navigator ran after the patient and said, what's happening? And she indicated, I'm tired of this. I don't have insurance. I don't need to be told this repeatedly. I did not come in for care because of that, because I've already been told I can't be seen without insurance. I was told you would help me, but it looks like you're not going to help me. So navigator went ahead and connected with patient and said, I think there was a miscommunication. Let me walk you back up. and went up there. And of course, registration has the standard question they have to ask, do you have insurance? So this made the patient upset. So navigator helped register and sat there and waited until the patient was being seen by our oncogeneralist, and evaluated and sent for a diagnostic mammogram. After the mammogram, she had biopsy and follow-up, which navigator supported every step of the way. Now, this patient was not diagnosed with cancer. So why am I sharing this patient's story when she wasn't diagnosed with cancer? It's because this was a patient under 30-year-old with 2 children that for 2 years did not receive any care because her doctor told her she cannot get screening without having insurance. So every night she was going to sleep with the notion in her head she might have cancer and there's nothing she can do. Once she found out she does not have cancer, she was completely thrilled, and the doctor did tell her, you have to take care of those cysts that you have, and we will help you go through that. So had the navigator not helped her, support her, and been there with her through this process, she would have not received this service. So what are some reasons why people do not get screening? Often we hear it's financial, they're uninsured, underinsured, and sometimes they have to choose putting meals on the table versus getting cancer screening. Sometimes it's choosing from options of getting medication for their children or treatment for their children versus getting treatment for themselves. And then there is the transportation. One of the story I can share about transportation, I actually love to travel to areas where I'm going to be working. So when I came to Chicago, one of my first project was in Englewood. And I decided I'm going to take public transportation, go to Englewood, just check the area out, and then meet my team there at the Miles Square Englewood Health Clinic. So I did take the bus, but I didn't realize there's Englewood City Clinic and Englewood Miles Square Clinic. And I ended up at the City Clinic. It was raining. So I realized I'm running late for my meeting. So I decided I'm going to get an Uber and just go to my meeting and then walk around afterwards. I sat there multiple minutes, over 5 minutes, looking for Uber or Lyft ride. And I got the same message from both apps, 3 or 4 times each, saying no drivers available at this moment. And when I checked for the bus, I realized the bus does not go to where I was trying to go. So I text my team member saying, hey, I'm at this clinic and I'm running late. I can't seem to find an Uber or public transportation to get there, so I will be running late. And she immediately tells me, stay where you are, do not come out, I'm coming to get you. She comes and gets me and says, are you crazy? Why are you in this weather out here? You don't even come in good weather out here by yourself and walk around. Why would you do this? And she takes me back to their clinic. So think about the population that we are trying to serve. If I could not, with my technology access, find a transportation to just get out of a clinic to go to another clinic or another location, how do we expect our community in these areas to come to their appointments where they have to take multiple buses, multiple public transportations, and get to their appointment? And sometimes when they get to their appointment late, they get a lot of feedback or comment that does not turn to be positive for being late. So one of the things, as we are providing care for our navigators or our patient population, we have to be mindful of where are they coming from. Them just showing up sometimes is a lot of work and says a lot. The language barrier tends to be a big one in our community, especially community that might be of foreign descent or even community within, because our patients don't speak the medical language we speak. So having a conversation, a perfect example is we had a patient that was informed, when she was informed she needs follow-up, she thought they told her she had cancer. And she calls in panic, trying to figure out what happened, like how did she get cancer and all those other things. Navigator talks to her and had to tell her, hey, it's not cancer. You had a positive FIT test. We need you to come in to get screened to rule out if you have any other underlying condition, or is the positive FIT test a false test, or what's going on. So Navigator helped us schedule a colonoscopy appointment. And this is a perfect example of that language barrier. When the patient was asked to come in, it was an immediate reaction of, her taking, oh, positive FIT, I have cancer, and not a discussion of, oh, what's the next step for me? Did not know, this is not an ignorant comment from our community member. It's something that even we can ask ourselves, how many of our parents, family members did not know they had to get a cancer screening, was not aware there was such a thing as cancer screening, or doesn't think it's necessary until there is a problem. And that tends to happen in our communities a lot too. And finally, miscommunication. Miscommunication, it can be language barrier, but the other thing that miscommunication can be is what happened during the COVID-19 pandemic, which is a perfect example. All our screening appointments were canceled, and patients were automatically assumed they no longer need screening. So they do not have to go back for screening. And this was something that our navigators had to reverse and communicate with them, that it's not they no longer need the screening. It's that now, due to the pandemic, there is a barrier to screening, and we have to reschedule for a different time. So navigators had a lot of phone calls with patients that informed that were being told by patients, oh, my doctor canceled my appointment. I don't need to come and see the doctor. That was the message they were getting with each canceled appointment. Genesis, if you can help me with the next poll. You're waiting for the result. So this is the poll result. Like, how often do you think of sexual abuse when you think of cancer? We have 7% of the population here that thinks of sexual abuse or abuse in general, and 75%, that says they think about 75% of the time. And then there's 50% and 25%. We have 36% that thinks 0% of the time. So this is a really, really good thing to look at. Sexual abuse and stigma plays a role in our cancer screening. So when we talk about stigma, there is the thing of, I don't want anything going in my butt. You can't let someone touch your boobs other than your partner. They're going to put something in your vagina. Don't let them do that. These are some of the things you will hear community members talk about and share with each other that we might not think of often when we are thinking cancer screening. And then the other thing with cancer screening, if there is colorectal cancer screening, cervical cancer screening, breast cancer screening, these are all invasive screening, touching sexual organ of the body. Now, if we look into the United States sexual abuse history of average population, we will learn that a large volume of them goes through some sort of assault or abuse. So these are individuals, when they're coming in for screening, they might reject the screening right away because of trauma. or because of fear, or just not trusting the individual who is offering the test, or does not want to trust the person touching them in areas that they have been abused and violated already. This happens more often than we think about it. And when we have individuals or community members rejecting services, they do not openly discuss this. Oh, I do not want, I have been abused and I will not be getting the screen, or I'm not interested in getting screening because I don't trust my provider because of my history and stuff. They often will just come out right and say, I don't want the screening. I don't need it. I don't trust it. I would rather get cancer than get screened. These are some comments you're going to hear from them. So this is where our navigators, community health workers, social workers play a role in building that trust with these individuals, and discussing and being there for them during the screening process. When all our navigators and social workers play a key role in connecting and processing. This includes, we have had navigators that set in appointments with our patients. And the reason for that is just to overcome their fear, trust in individuals, and also to be there for them at a time when they're feeling vulnerable. Our navigators are often trained for mental health, and they're trained for also identifying and referring individuals that have had some sort of trauma, and also individuals that have that need care for that traumas and redirecting them for care. So what do patient navigators do? The best thing I can say, the best example I can actually put of a patient navigator is a woman, a mother of 3 that is working a full-time job, raising children, probably going to school and have a gazillion other things going on. So they are multitasking every way through. So some of the things they do is they assist our patients with overcoming barriers we discussed earlier. They support the patient, provide education, and link them to services and care of their choosing. Now, earlier I mentioned about appointments were being canceled and miscommunication. So patients, this is one of the impact, this is the impact the pandemic had on our patient population. One was the miscommunication. Canceled appointment meant I don't need it. The screening doesn't need to happen. I don't have to come back. And then the next thing is overcoming that miscommunication is rebuilding the trust and support. So saying, no, you need these appointments. You need to come back. Your doctor did not cancel your appointment because you don't need it. It's just the pandemic causing issues, and we have to get you back. And the last thing is getting that access to care. So even if the navigator connects and gets that support and clears that miscommunication, one of the things we see right now is long wait time. So colorectal cancer screening, if you are an average risk person, you might be waiting 7 to 12 months for getting a colorectal cancer screening. Breast cancer screening, individuals have reported 3-4 months of wait time in some places. So these are, and then there is the backlog of patients that have to get those screening, while we have the future patients that need to also be engaged and linked to care. So this all goes in hand, and the pandemic has played even a bigger role in making our access harder for our patient. And a perfect example of how patient navigator worked with the patients during the pandemic is our positive fit patient. So a young lady in their 50s had a positive fit test and was called by navigator, an appointment was scheduled, and the navigator just called to say, hey, did you go to your appointment? How did it go? And found out patient did not go for the appointment. And she said, oh, I don't have to go for my colonoscopy. My doctor canceled the appointment. And so the navigator explained to the patient, no, you do have to go for your appointment. If you don't, the reason for your appointment is to make sure that you don't have colorectal cancer. And if you don't, the more you delay, the more likely it is to get worse. So let's get you to your appointment and let's call and talk to your doctor about it. So they called the doctor, connected, and they of course discovered she has to come for her appointment. So the navigators helps reschedule this appointment. Once this rescheduling happened, patient was informed she needed a COVID-19 test, a negative COVID-19 test, in order to get screened for the colonoscopy. And so the navigator helped her schedule the COVID-19 test. There wasn't any walking to get COVID-19 test. At that moment, it was you have to get an appointment and get the test done through that. So the patient got the COVID test. It was a negative test, and she went for her appointment only to find out the GI did not receive the negative test. So they couldn't see her that day. So she went through the whole procedure of preparing for a colonoscopy and only to find out they don't have a result for COVID, so she can't do it. So navigator helped patient reschedule the appointment and reschedule the COVID test, and ensured with the tester to make sure that the test results get sent over, and also talked to the doctor's office to ensure that to work with whoever is testing to get that result so she's not sent back again. And patient went and got her COVID test, went and got her colonoscopy, and found out she had multiple polyps and they were removed. The GI told her, you are very lucky that we caught your polyps at this time. If you would have waited for a few months or years, I think your prognosis would have been completely different. So this is the kind of things that navigator had to deal with during the pandemic. It's that communication, results are not coming in, results are incomplete. They are not being communicated with. GIs might not have the capacity. Patient does not feel like she needs the appointment. One of the things actually at UI Health during the pandemic that we did was the patient navigators partnered with Dr. Lauren Green and her team to reach the high-risk breast cancer population. And they were individually calling all the high-risk breast cancer population and scheduling them to come in for appointments and making sure that they're getting a call back before their appointment to remind them that they need to come in, and the importance of that appointment, because that cancellation automatically for a lot of patients meant, I don't need that appointment. Now, another interesting thing that navigation trying to do is they go beyond the support of just, get screened, get treatment, and you're done. Here was a patient we actually had. It was very interesting. Patient just found navigator's phone number and called and said, I need nipple tattoos and my insurance is not going to cover it. Is there any way you can help me get my nipple tattooed? Body image plays a key role in our survivors, how they succeed, how they feel about themselves, and how they're going to get better and back to, everyday life. So when Navigator heard that, we had never actually provided any support prior or had discussion about nipple tattoos or other tattoos that can support patient. So we never had the resource right offhand. The Navigator immediately said, oh, let me look into this and get back to you. And she searched throughout the nation and found 2 organizations that can help this patient get her nipple tattoos. And she doesn't have to pay. So she connected the patient with one of the organizations and linked them to get her tattoo. Few weeks later, patient text messages the Navigator and says, I got my tattoos and they look really good.
Hello.
Hello there. I was just happened to think I didn't hear back.
Okay. So patient was very excited, responding to reaching out to the Navigator, texting her and talking about her tattoos and exchanging messages. And this was the kind of excitement that sometimes Navigator works with. And these are some scenarios that they come across. During the pandemic, there was so many resources that patients had to provide to navigators just to address their concerns, isolations, and follow-ups, and also self-image related concerns. Now, when we talk about navigators, it doesn't necessarily mean the title navigators are individuals that are doing these services. UI Health has a lot of resources. This includes Cancer Service Line, patient navigation through MileSquare, the Cancer Center, Oncology Department, and the Emergency Department. And then there is the care coordination at UI Health, and then the UI Health Psychosocial Oncology Program, and the insurance support program. And I think on this, the survivorship lecture series, we did have this UI Health Psychosocial Oncology program come and talk about their services. So all these services at UI Health provides some sort of support and some sort of help in navigating through a patient's care. So it does not have to be, hey, community lay navigators are the one that provides this service. It's all these programs that work together, work with each other, that makes all these services happen. I do not have contact information of all these services. However, I can make a list of all the contact information and the contact person and reach out to provide it to Dr. Mentz to share it with the attendees. Now, I do have I want to change the conversation into community engagement and research. So if Genesis, you can help me with the question. So about 50% of the attendees here engage with research and with the community, and another about 57% engage with research, and 43 does not. So one of the things with patient care, research, engagement, it is essential that we are involving our community in deciding how do we deliver our services and our care. Because just because we as researchers, providers, medical staff feel like, hey, we are doing you a favor bringing this service, or we are trying to better your health, but why aren't you receiving this care? Why aren't they understanding? These are not methods that works with our community. There is no reason for our community to trust you unless there is a trust built up first. In our childhood, we are taught stranger danger. Whenever we grow into adults, that concept does not magically disappear, especially in a community that has already been negatively impacted by researchers. Our community's trust has been broken. They have been used and abused in the name of medical discovery. Their body has been violated without consent, and you all are strangers to them. We are talking about a community we can't even access. I can't even get an Uber ride out of. Like on a day-to-day basis, they're not seeing individuals that are trying to provide them with the help, support medical care. Some of the areas our patients come from are medical deserts. So there is no doctor's office, there is no oncologist, and there is no service lines or others to help them. So just to come in and say, we are here to improve your screening rate, we are here to improve your cancer care, or we are here with this research study, does not excite them or give them a reason to be supportive. So this is why we can't blame our community when we are trying to provide some services or do some research work and they are not enthusiastic about providing you with that support. So one of the things we definitely want to do, why we should engage our community, is to make sure we are strengthening the link between research and the community, but also enabling a trust building. and being able to contribute, give the community a chance to contribute meaningfully instead of just putting check boxes on our research studies or on our health quality measures or on our other programs that we have in mind. And also, if you want the community to access the research meaningfully, you want to be able to engage with them and get their feedback, get their support, and get their buy-in. If not, your study will not be moving forward. 1, 2, the results you might be producing from it might not represent what the community really lacks, needs, or is wanting to get into the community. So how do we engage our community? And when we are engaging our community, we want to make sure that it's not only because of research, but also for education, encouraging to get medical health and improvement. We want to be able to partner with them based off of the community-based organization that exists in there and the trust they have already built up. Be a part of the resource they already have before we start putting in resource and building things that we think they need. Being truthful about our studies, like what are our intentions? Why are we here? And what are we going to get out of you participating with us? And what are you going to get out of participating with us? So having that honest conversation, so it's not down the line, oh, they lied to us, they did not give us the full information, they did not disclose to us, and they just came here to get something and leave. And go back to the community with results. Like, it's very important for them to hear, oh, this is the study that we did, and here are the results from the study that we carried out, and this is what we learned. This is what we are planning to do with that information. And don't just be the researcher that just takes. Be the researcher that shares, gives, and think about sustainability. It's very hard to build trust with our community. Once you have built that trust, you don't want to just drop it and walk out, because then the next person that's going to come behind you, they're not going to have that opportunity to build that trust, because they know the researchers are going to leave. The community organizations are going to leave. The study is going to leave. So one of the things that we want to be always mindful is, how do we sustain this? What is the next thing that's going to come out of this? And this is going back to sharing your results, your thoughts, what's the next step? I have often seen researchers going to communities with brilliant ideas, get the community excited, and then just walk out after that. So that does not give somebody any reason to say, oh, let's build that relationship again with the next person. Work in collaboration with each other so you can support. Work in collaboration with existing leaders. At CE, I actually lead, as Deborah mentioned earlier, I lead the research collaboration where I connect researchers with community organizations and community leaders that best fit their study, so that they can include them in the study, get their feedback, get their voices, and be able to share that again once they have the results, and bring it back to the community. And this also helps the community gain their trust, because their leader is going to them and not somebody that's coming. A stranger danger is coming with a study and saying, hey, I'm here to change everything. And then all of a sudden you're no longer there. So that's all I had for community engagement and research and navigation, and how to engage navigators, and what are some things that navigators do. Do you have any questions for me?
Before we open up and get some questions, I just want to thank you for speaking this morning, Nasima. It's very helpful. We're all so in this, that it's good to have a talk like this to help us step back and like think about those things that don't come to mind, that, you know, the transportation issues, or how patients are feeling. my doctor canceled my test, I must not need screening. That's not even something I even thought about. And it's very important to be able to frame, talking to your patients and be able to think about these things. So I appreciate your perspective.
Yeah, thank you. It is not often that we do think about this. One of the thing we came across one time was a patient that showed up with 2 kids for her appointment. And here was the front desk very frustrated with the patient that has 2 kids with her, that now she has to register and see in and keep in control so the kids don't take over the waiting room. And this was in a training actually we were doing for IDPH, and they brought this up. Now, the thing was the patient was there. She came. She did not have somebody to take care of her children. So her choice was miss her appointment or not get screened or just show up with the children and get screened. And sometimes we are not understanding that part, that they are sacrificing a lot to get there, to be there. And it doesn't, sometimes you can't blame the staff for not thinking it, but then this is where we come in and say, be mindful, why are they late? Why are they not showing up? Why are they showing up with children? And why are the children these are the individuals that are not sitting still. It might be the children didn't even get anything to eat, just got pulled out and just brought on the bus to come for this appointment and for the mom to get screened. So yeah, it's being a little mindful and taking a step back and saying, what, she's here, what could be going on?
Yeah, there are those layers that don't come to mind right away. And yeah, a lot of our patients are caretakers for family members or things like that, see a patient no-showed for an appointment. You don't have any context, but it's important to think about all those things and have these navigators to be able to reach out to those patients and try to help them to get that test done. So that's really great. Anyone else have any other comments for Nasima? Any other questions? Go ahead and unmute yourself and.
Hi, Nasima. Thank you. This was such a great presentation. And I think, like Dr. Mann said, just sort of brings us back, taking a step back to think about how complex it is to navigate your way, into and through your healthcare appointments, and stay empowered to do this and sort of navigate the complexity, I think, of a healthcare institution. There's a lot of attention being paid to organizational literacy, right? That patients have, and how organizations and healthcare institutions can become more literate to provide more equitable care. And I wonder what Sihi and what the navigation team's sort of thoughts are on sort of health literacy and especially as it relates to organizational literacy, right? I mean, there's personal literacy and there's health and there's organizational literacy, and sort of how that plays a role in some of the experiences that you and your team have had around that, and what we can do to improve that at UI Health. Because I think, there's a lot of attention right now being paid on improving the patient experience and patient satisfaction with our organization. And I think that the navigators can really step in and help here and really inform some of the improvements that UI Health can make. So I'll stop there. I think I asked like 5 questions in all of that, but go ahead. I'd love to hear your.
So no, those are some great questions. And one of the things recently that that's happening is insurances are working and to reimburse community health workers, community health educators. And that's something that shows the power of navigation and education that's needed for our community members. Now, it's a great question about organization literacy and patient literacy that you asked, because some of the materials and education that we share, after the first 2 lines, are we really reading those information? Probably not. I was just having a conversation with somebody about cancer research and putting the subject matter down to like 4th grade. And our marketing team joked around and said, hey, we do it at 5th grade. And he said, we do it at 4th grade. So that's something very essential to remember. Our community cannot read at at the literacy level that we think that we are sending out the information. And the other thing is when developing this material, who is developing it? Is the community voice there? Did we run it through a community member saying, or a group or individual doing a survey saying, hey, what do you get out of this pamphlet? If we don't have their feedback and we say, oh, this is 5th grade level, that means nothing. That just means you might have used the words, but did you use the overall context, material that go at targets and attracts that community members for coming in for screening. So I think for organization literature, one of the things we definitely need to do, or organization material, we definitely need to do is be more mindful and engage more community partners in doing surveys on the materials we are providing out or sharing out with the community, because they need to determine, is this what's going to bring them in?
Great. Yeah, no, thank you, Nasima. And I think, I think that we're starting to think about health literacy beyond just their ability to read and, patient education materials. So I love, Courtney, thank you. I think that your team is so important here in helping us design materials that can really engage patients and inform patients to make decisions about their healthcare. But I think we're now even moving into how an organization becomes health literate in terms of reducing its complexity and allowing patients to really be able to navigate and get those appointments and get through their appointments and understand the tests that they need, but to schedule all of that and get through that in a more simple, way. It's a very, very complex thing. And I think this is where navigation really provides a service that helps that patient overcome those barriers, identify what is getting in the way, and again, how to sort of get the care that they need. It's not easy. And so I want to think beyond just even the handouts and think about how we are designing our organization and our care to be really more simple, and allow patients to utilize the services that we have in a more simple way.
That is a great observation, Dr. Gansha, and a comment to make. And one of the things I'm definitely going to say is thank you to your team. Thank you so much to your team for being available in ways that we have not seen providers often available. We can walk a patient to your office, like to your department, and be like, Dr. Gansha, this patient needs to be seen. And you're like, oh, I will see them, squeeze them in, or put them on my schedule at this time, or I'm going to be here at this time. Like, that's something we didn't see. One of the things we turn to see when we walk in Wednesday, our patients can't have these scheduled appointments sometimes because of all the barriers I just discussed in terms of transportation, in terms of daycare, in terms of taking off of work. Some of them are working 2-3 jobs. So when we are giving them a scheduled time and saying you need to be there at this time exactly, we are forgetting about everything else that's causing them not to come in. And then the next thing is when they're there, one of the things Dr. Kiriaski and Cancer Center has been talking about is that blood-based test and that biomarker test kind of thing. And that's something great for our community because, they're coming in for an annual exam. Then they have to get a referral for a colonoscopy. Then they have to go for the colonoscopy, then get a referral for breast cancer screening, go for breast cancer screening. And it's that repeated number of visits versus if there's a blood test or that they can do at their annual visit, you have done all the cancer screenings and all other screenings at one visit, and these multiple visits don't have to happen. And then the conversation of, how do we make our health system more patient friendly? I will agree, like, even though I work in the healthcare field, for me, it's a hassle of, HMO insurance. Are you in network? Is this being covered by my insurance? Where do I go for care? What's my next step? Who is scheduling my appointment? Did I forget an appointment? There is so many things that takes place. And when somebody in our community is coming in, they're going through all this and they're not even working in the healthcare field. So to be able to just leave, I think one of the things is training our front desk staff and our providers to make sure that that plan, what's the patient care plan, step by step, step 1, step 2, step 3 is written. I really do like that we went into the EMR system that we have and the Epic system, that it's more communicative. We have room for improvement, but I think it allows to see overall communication that's happening. So we are in the step of right direction, but it's just now making sure our staff and our team member are informed, and we are having that plans, those steps, and preventing patients multiple unnecessary visits if they don't need them.
That's so true, Nasima. I often think about how hard it is to navigate healthcare myself, and I'm just like, oh my gosh, think about patients and what they're going through, and because they have no wherewithal of any of this. So do you want to pipe in? Our patient, Candace Henley, is here to talk about the other side of things to help us think about and contextualize all this.
Oh, I would love to. Candace?
Hi, sorry I came in late. I just saw the email. I'm catching up. It's been quite busy since I've been off with COVID, so I'm just catching up. So not quite familiar with what you were talking about previously, so I apologize.
Yeah, Nasima, you want to summarize for her and ask her opinion?
So we were just discussing about the complex healthcare system that we have to face on a day-to-day basis, and just the number of visits and the complexity, and how can we help make that system better for our patient, and what is the direction we should be heading.
Gotcha. Well, I'm always a supporter of removing red tape. The more red tape and hoops you can remove for the patients, the better off it is, because the patients are already doing enough. And I always think it's a good idea to do a hard pass or handoff, so to speak, to particular services like navigation services, so that the patient is not busy trying to call a number all the time, right? But maybe having the navigation department being able to, hey, let's connect, let's connect you with the patient, and then connecting the patient, vice versa, making sure that there's a bridge, so that, and making sure that there is an avenue that the patient has directly to services versus trying to figure out where and who, okay? Because that's a challenge. And so when I'm busy surviving, I'm also trying to live. And so I remember going through the process, having numbers to call after number after number after number becomes challenging, and it's off-putting, because now, in addition to me trying to manage numbers for my day-to-day care, now to find services, I have to call this number, and that number may not be available. So making sure that whatever resources that are given, the information is kept up to date, so that the patient is not in a continuous loop of information that is not viable. And then one of the things I think is important is always asking the patient, has anything changed since your last visit? Has anything new developed since your last visit? Are there any barriers that might keep you from making your next appointment? Is there any help outside of medical that you might need? And that helps open a door for conversations for patients who might not readily admit they need help. But being asked those questions can be very helpful. And that's all I have at the top of my head right now.
Candace, thank you for those comments. And your first one makes me think, Dr. Esther Reed did develop a kind of patient and provider facing guide that we're now taking a look at and getting updated with all of the cancer supportive services. And things often change, staff change, numbers change, contact or development of new departments, closure of some departments. So we're trying to do that. And I want to ask you, how would it be best for a patient to receive that information? How would it be good? Should their providers give that to them at their visit? Should that be available on the internet? Is there some other way that we can get that to patients?
Well, you know what? We're in an age of technology, right? So being creative in the usage of my chart is amazing, because that information goes directly to the patient, and it's in the privacy of their own home, right? So again, we have to think about the mental aspect of being embarrassed about certain situations. So at least if information is being communicated, hey, just in case you didn't know, here's some services that we have available. Because when I received the flyer for the webinar, that was great. It was right there in my chart.
Right.
So that's a great use of being able to use my chart, right? Because, you know, I mean, what's the point of it if you can't use it for, you know, for helpful information as well, you know, beyond healthcare. I mean, but I mean, this is a way to privately receive information without feeling overwhelmed and embarrassed. But you know, but hey, here it is, and they won't lose it, right? Because it's right there in their chart.
Yeah, thank you for that feedback. That's really excellent. That was our first time sending something out via my chart, and very glad it was received so well, and something that we can utilize more and more in the future.
And I would definitely like to echo with Candace that it is great to utilize the My Chart. You know, it's a place where they can get information, but also with that, making sure that our staff and our patient is getting the training to be able to access to it. And also we have to remember there are some of our patients that do not have access to My Chart, do not know how to access it. I know my mother-in-law refuses to get her health records online. She's like, I don't want to use computer. I'm too old for this. I just want my paper copies. So to be able to have the team recognize, okay, this person can, you know, do My Chart, we can provide that resource, but also the population that doesn't have access to the technology or does not want to access the technology, we want to be mindful of those also and make sure that they receive the support.
Absolutely. But I also think this is an opportunity to encourage usage, right? My mother uses My Chart, and my mother is not tech savvy, but during the pandemic, that's what we had to rely on. And so that's something that I encouraged my mom to learn to use. And it might be a great opportunity to have maybe sessions where patients come, you know, older patients or patients who are not tech savvy, but they have phones that can access it, can learn how to use that. And then this is an opportunity too for the staff on the other side. And this is how I always relate this to staff members who are resistant to learning or doing the most that they can. Imagine this was you and you were in a desperate situation and you needed help. Where would you want your help and how would you want people to respond to you? When people are in desperate situations, they need as much help as possible. And you could be that defining factor that can make or break a patient in a desperate situation. Because the lack of help that I received broke me in ways that I didn't think that I could. And I'm a strong individual, but after getting door closed after door closed after door closed, I could have used someone to have some type of compassion and empathy. And when we are, and yes, the world is moving and we're always busy because everybody's like, okay, I have this patient, I have that. But sometimes, I'm not gonna say sometimes, in this situation, patience and time is of the essence for everyone, not just the people that you are, you know, you're working with at that moment, but for everyone. And so that time and that patience utilized for that patient can be extremely helpful. So it's always helpful to remember that in this situation, it's necessary.
Nasima, are any navigators on Epic on My Chart? Are they able to communicate with patients as well through the chart?
Yes, so navigators have been on Epic and they are all trained for being on Epic and seeing patients' records. And they're able to communicate not only with patients, but with providers. So that's I think that was earlier I mentioned that we are in the right direction in terms of going into Epic and using that, but now it's the next direction of how do we make it more friendly and accessible. And as Candace mentioned earlier, don't give me a number. I know when I was doing a cervical cancer project, one of the thing was, the providers always saying the patient's appointments are not being scheduled. So instead of giving a number to schedule the appointment, why can't it be scheduled when they're checking out? Like the checkout, can they schedule the appointments that they need to have in the next 3 months, 6 months, 12 months? And if they can, let's leave with that so they don't have to make one more phone call, one more follow-up, one more number, and one more wait line. Instead, everything is taken care of at that visit.
I do want to acknowledge it's after 10, so anyone that needs to get going, you go ahead, and thank you for attending. But I'm happy to stay on if anyone wants to stay on and continue this conversation, because we have lots to say about this. We'll have to bring you back, Nasima, at least once a year to start this conversation and talk more about all the different ways we can help our patients out.
Thank you. Thank you for having me over.
Thanks, Nasima. Thank you, Candace, for those really important highlights. I think we can't hear enough about the patient experience and thinking about how we need to redesign our care. I think it's so important as we do this, and I know this is a big focus of UI Health, this year is working on that patient satisfaction and patient experience. I think it's so important to have our navigators and our patients like Candace and, our community advisory board members, especially our patient advocates, on the committees that are driving and informing the changes that we're going to make here. So, and I know that cancer, what we're experiencing in the cancer care spectrum is also happening in diabetes and in other, complex illnesses. And so I think these are lessons we can learn and apply to the way we deliver care across many different disease areas. So thank you, Nasima. Debbie, I wish I could stay on and we could keep talking, but I've got to hop off. So thank you, everybody.
Yeah, thank you, everybody. Thank you, Courtney, and thanks for coming, Candace, and popping in and talking with us about it. So always great to hear your thoughts.
Thank you. I'm sorry. I was kind of late, so I apologize.
I
but it
hope you
sounds like
feel
it's great.
I hope you feel better soon. When did you get COVID diagnosed?
Last